Hello, welcome, Rick Bukata and my dear friends, Rachel and Kevin. This is the April issue of Risk Management Monthly, and this is a little special issue. First of all, we're catching up on emails that go back to 2019. And after that, we're going to catch up on those emails. We're going to have a special treat for you, but you have to stay on, and I'll tell you what the treat is at the end. But first, here's an email. A listener wonders what case law would apply concerning the liability of ED orders not fulfilled. For example, like failure to take blood pressure in both arms when requested in a chest pain patient, or failure to give a first dose of antibiotics before the patient is discharged. This person is asking, does the captain of the ship principle apply here? What do you think? Well, we have two lawyers now. What do you think, guys?
You first, Rachel.
Oh, I was going to say it's such an easy one. I was going to give it to you.
Well, yeah, I appreciate that in my current post-travel state. But no, go ahead, and I'll clean up anything you leave behind. So,
all right.
Not that there will be anything, of course. You're brilliant.
So I think this is pretty clear that yes, the captain of the ship doctrine would apply here. You know, this is basically asking if somebody comes into the emergency department and the standard of care is not met, would the physician be liable, even if, they had placed an order and somebody else didn't carry it out? And, ultimately as a physician, you're responsible for the care that's given when the patient is discharged, and, for seeing to it that whoever is under your chain of command is doing their job. And so if patient gets discharged, you sign that discharge and you didn't kind of go through the checklist and make sure that the things happen that you asked to happen, that you're responsible for that. So I don't have case law pulled up to support that, but there's a lot of it out there. And you can come up with a bunch of different examples for this. You order a dose of medication, discharge the patient, they didn't get it. Yep, that's on you, even though you placed the order. You ask for a cast to be placed, somebody else places it, it was too tight, you discharge the patient, they come back with compartment syndrome. Yep, it's on you, even though somebody else placed it. So absolutely, there's a ton of case law out there. You're the boss, you're the one that's going to get stuck with the responsibility.
Yeah, I'll just add, and thank you, Rachel. I agree with you completely. Don't have much to add at all, except in the cases that I've worked with previously, oftentimes they do hinge upon this. And please remember, our colleagues oftentimes think this is their day in court. This process is supposed to vindicate them because we're looking for truth. That is not the purpose of this process. The purpose for your attorney is to defend you. The purpose of the plaintiff's attorney is to represent their position. Somewhere in between might be the truth, but when they look at the charts and they look at the documentation, they're looking for multiple avenues of allegation, and they're also looking for multiple policy limits. If they see that the nurses didn't carry out the orders that you instructed them to, they're not going to say it's just the nurses. They're going to say it's the nurses and you. And remember, the nurses are the agents of the hospital. So then they bring a bigger pocket into it. So Rachel is exactly right. If you wanted, your duty isn't to write an order to do bilateral blood pressures in a chest pain patient that has radiation to the back. Your duty is to make sure the blood pressures get done. The order is the vehicle with which you use. So you are obligated to make sure that happens. And when it doesn't happen, it reflects you wanted it to happen, you thought about it, and you did not execute faithfully on that order. And it's you and the hospital and the nurses. So it just adds additional people to the claim.
Well, there you go. A 2 for 2. You both agree on the answer here. One of the things I would suggest, however, is a person leaves and they didn't get that antibiotic. It would seem to me that it would be appropriate that you tried to do something about it. If you thought it was important that they take it, that you give them a call, you said, I'll call it into the pharmacy, that you take some kind of action rather than just say, okay, well, they didn't get their antibiotic. When you recognize that has happened.
Well, I think, Rick, when on those cases too, where these issues are often ancillary to the primary core allegation that I've found, but they do provide evidence that maybe you did not execute on your duty, which means you fell below the standard of care. But I will tell you that in these cases, you should reflect in your documentation what you're trying to do to help the patient. You absolutely should. but you can't always accomplish everything that needs to happen, but you should do your very, very best. And that is the importance of documentation. So if you think that something should have happened and it didn't, document that you're trying to help the patient. That will go a long way in your defense.
Gotcha.
Oh, and really quickly, the final thing I want to say on this, I almost forgot, is that remember these nuanced pieces, they still, even if there is alleged negligence and there are damages, the missed antibiotic still has to be the direct and proximate cause of the damages. You can still have negligence. It was negligent not to give the antibiotic. If it didn't cause the damages, it doesn't matter. You're allowed to be negligent if it didn't result in the harm. That has to be proven.
That's kind of like a slippery slope there.
Yeah.
But you gave some antibiotics already. Will more antibiotics have increased the likelihood of recovery of this person? Tough case. Rachel, you have actually, yours is more of a, what is yours?
Ours is a little bit nuanced. You're going to have to remind me or see if we can.
Oh, yeah.
And,
Now I remember. I mean, yeah, this is a complaint. It's.
Yeah, you're going to
This
have
basically-
to remind me what the complaint was about. But
All
we
right.
did have a discussion months and months ago about, there was an article looking at medical boards and COVID treatment. And basically the article centered on, there were some medical boards that were sanctioning physicians for not kind of following the party line on appropriate COVID treatment. So some physicians were, I think, prescribing ivermectin and doing things that were, I think, even more outside the lines than that. And the medical boards were sanctioning them. And we had a discussion about that and what the appropriate role of the medical boards was. And a listener wrote in and they were disappointed with us.
Well, because they wanted to take the other point of view that it's not really necessarily what they ought to be doing. So what was their position? Do you recall?
No, I don't know if
mean,
I saw this.
Well,
complaint,
anyway,
to be
I'm going to tell you
honest.
what their position was. It was, some of these treatments, which sound a little wacky now, in the past, there's been treatments that were, or theories that sounded wacky that turned out to be true. And some of them sounded pretty far out, like everybody knows an ulcer is caused by stress. That's obvious. But the fact of the matter is it was caused by a bacteria. And those people at that time, when an ulcer was caused by stress, everybody knew that. There was these wacky doctors that were saying, "Oh, wait, no. We think it's caused by bacteria." And that you want the medical board to shut those guys down because they are so far off the bell-shaped curve that we need the medical board to sanction them because these guys are given antibiotics for ulcers. Where do they go to medical school? Just trying to help out here.
What's going to be tough is really holding plaintiff experts to the timeline of evidence. So I think we're going to start to see a lot of these cases coming up because they take a while to get filed. They take a while to work their way through the system. And people are going to apply current facts, which we had an explosion of literature to decide what to do about COVID. But when some people were using some of these treatments, they were the kitchen sink sort of thing. We got to do something. We're not sure what to do. If anything looked hopeful, people were using it. And I think there are going to be a lot of experts to say, well, look at this JAMA article, this New England Journal article. Wait a minute, that came out 2 weeks after the dose was given. So I think we're going to see some of that. And I do give those people a bit of deference that, yeah, if we didn't know and you had very extreme conditions with a patient and you wanted to try something that was somewhat unknown or experimental, fine, I give that to you. But if you continued that practice after the evidence came out that it was not helpful, and you omitted other important treatments that might have been helpful, then I think there's going to be some liability exposure there.
And especially if you were proclaiming the benefits of your treatment to the world, and what was going to what was the medical board going to do about that? Because you may be harming people suggesting this treatment works when it may not. And so the issue was, is this the job of the medical board to step up when they see something like this? Is like, you know, more extreme example of this is they shut down a pediatrician here in California who was a bit of an anti-vaxxer, not related to COVID necessarily, but he was against COVID, but he was also against other vaccines.
I think
because there was all this thing about belief that autism was linked to some of these immunizations, and it was the mercury in them, whatever it was.
Yeah. So I just
medical board went down on this doctor.
I just pulled up the article that I think we talked about, and it was primarily the medical board sanctioning physicians that came out citing false information about vaccinations. And that, you know, the reason that they came out with those sanctions was because they felt that the anti-vaccination statement was harmful and that it was convincing a number of people to not be vaccinated. And they felt that that had, you know, indirect harm.
So the Federation of State Medical Board came out with a very strong statement, and I really applaud Hank Chaudhry's efforts in doing so. When I was with the American Osteopathic Association, we were one of the organizations that that supported it publicly, because once you are you're beyond scientific discourse, a difference of opinion between clinicians, the evidence is clear one direction or the other, and you're perceived to misinform the public, then you damage the public trust in healthcare and in the physician community. That's what the concern was from the medical boards. And I think you have to be way outside the boundaries of a difference of opinion. And if you really are misinforming people, and I think the vaccine issue for COVID was a really good one. There are still people who believe many things about vaccines, but one of them is that they didn't help at all. Well, we simply know that isn't the case. And so for people to say that they're not only not helpful, but they will hurt you and harm you in certain ways, which were unfounded, that's where the state medical boards really had to intervene, and they did sanction some people.
Right. And I think that's what our discussion was that, you know, I think where we went with the discussion was the state medical boards, you know, have an obligation, and it's part of their, I don't know, their scope to guide the professionalism physicians. They have the ability to sanction physicians that they feel are acting in an unprofessional manner. That's kind of outside, and it's not a legal action. It doesn't have to rise to the level of malpractice. If they feel they're being unprofessional, then they have the ability to do that. And we felt that that was appropriate. And the comment that we got was, you know, they didn't like that. They felt that that wasn't, you know, that was a one-sided discussion. And probably we touched on somebody who felt, you know, differently about vaccines and whatnot. But honestly, you know, so we're bringing it up because obviously, you know, people feel differently, but I would say the same thing.
No, I agree with you. And I would just say, for the person who had the concern, the medical boards were put under a lot of pressure because they were not being responsive enough. Right. And the community said, listen, there are some people that aren't saying, you know what, here's a positive of a vaccine, here are some negatives. You really want to think it through. That's good discussion between a clinician and their patient, for sure. What they were talking about, people who didn't have sufficient background, were not experts, holding themselves out as experts, and then suggesting that there were really, really horrific side effects that had no basis in the literature to support. So very far left of center. That's what they were targeting. So if the person was concerned that you can't have a fair and even discussion with your patient, there aren't two sides, we agree, I believe, and also the state medical boards were not pursuing those individuals. These were only very egregious cases. And
there was so much misinformation that even, you know, physicians that were deluged with trying to take care of patients or just whatever, that the chaos of the moment, we're having a hard time trying to figure out what are we supposed to be doing? What is going on here? And I think it was important for a scientific body to say, this is where we stand. And, you know, that's, I think, what the medical boards were trying to get that message across, like, hey, it's not okay for physicians to be standing out there and spouting this misinformation.
I think got a little bit more. One thing I'd like to add is that I think the reason all this happened too, tell me what you think, Rachel and Rick, but is because we politicized this medical issue. And when you would find the lines would be drawn based on a political affiliation, it's bizarre when you think of it. And we couldn't undo it. All of this kind of fell around an election cycle, and it's very interesting and scary at the same time to watch.
Yeah.
Right. So that was the gist of it. I think that there is more gray when they started talking about medications that might help rather than vaccines. And so, the one at the top of the list was ivermectin. Ivermectin was in, out, 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 kind of thing. Let's do the next one. This is a case about something that's not supposed to happen. A death due to a penicillin reaction in somebody who didn't get penicillin. They got something related to penicillin.
Yeah, I remember this one. And I tell you, I'm fascinated by this topic and have been for years. And the cross-reactivity from cephalosporins to penicillin is actually pretty minimal. And we have been really cautious for years about this, but I think we're overly cautious. In the interest of time, I won't go into the details, but there's a lot of literature on this. Cross-reactivity used to be reported at about 10% true cross-reactivity. We know it is substantially less now. The people who report an allergy to penicillin is far, far greater than the people that actually have a true allergy. And then the cross-reactivity is really, really small. So I'll just tell you, cross-reactivity for patients reporting penicillin allergy is about 1% compared to 2.55% in those who have a proven allergy to penicillin. And oftentimes it's because of the R1 side chain, which isn't in further generation cephalosporins. So it's pretty fascinating. Third, fourth generation cephalosporins don't even R1 side chain. And just to bring this home really quickly, to further emphasize why this should not be a concern, you'd have to have basically two independent allergies for this to happen in most people's eyes at this point. In the surgical literature, this has come out. Cefazolin is an amazing agent for preoperative administration to avoid postoperative infection, better than anything. And they haven't been giving it when there's a penallergic patient because this issue. Do you know that there is clear evidence that states if you give something else, that the postoperative infection rate is significantly higher? High quality, credible evidence. So in the orthopedic literature in particular, they've said, listen, you should give it unless there's a true allergy to the cephalosporin. And some of these allergies as well are not life-threatening, so you monitor for that. So I think we need to open up our minds. If a cephalosporin is the right agent and there's not a true allergy and it's not, something significant, angioedema, anaphylaxis, something like that, you should feel comfortable giving the drug.
My 2 cents were that did the patient really need the antibiotic? There's a high likelihood that they didn't. This is a case for by way of recollection. This is a kid who got amoxicillin like the day before and cephalosporin the day after and died of an allergic reaction. And so my questions were, was the antibiotic necessary? The answer is usually no, 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 no. Were there no alternatives to that antibiotic that could have been given? And there always are alternatives. I often wonder, how can you trust the description of a penicillin allergic reaction that happened when Johnny was 4 years old or 7 or 8 years old, when now he's, 18 or 20? Were there hives? Were there not hives? Was he wheezing at all? Not, those kinds of things are nuanced, but really make an important difference. But I do acknowledge that this is statistically a very unlikely event to occur. But I would really be kind of annoyed if it was my kid who died as a result of this, when there was other factors like, well, he didn't need it in the first place, or why didn't you consider drug X?
Well, Rick, 2 things. First of all, based on prior comments before we got started today, and this is for Rachel's benefit, it could have simply been Johnny's macaroni and cheese delivered by his mother. It did not have to be the amoxicillin, that's for sure. It could have been something else. But really what's fascinating to me in the literature right now is people are saying these really bad ones, they probably had 2 independent allergies. So just because someone reported a penicillin allergy and there was an allergic reaction to cephalosporin doesn't mean it's related. They are two independent allergies. And I think we're going to have to evolve our thinking. Just for the quick reading of the listeners, two articles that I think are worth looking at. Use of cephalosporins in penallergic patients, a literature review, Journal of EM 2012. That's Campana, Campagna. The other one is more recent in the surgical literature by Sousa Pinto. That's a hyphenated name, JAMA Surgery 2021, March 17th. Both really good articles that really focus on this.
I have a couple comments on this. First of all, this case, two separate comments. One, I think if this went to trial, which it did, you're going to have a hard time bringing in experts to talk to a jury to be like, well, the R side chain, actually, we don't think this allergy is real, because you're going to find a ton of articles showing if you have a penicillin allergy in a patient, then the cephalosporin allergy is likely, and a jury is going to see those articles, I think. And, that story is going to be equally, if not more convincing to them than these newer articles showing that the R side chain cross reactivity is not compelling.
Kevin, I think he's kind of mocking you.
Well, I don't see
I'm
not saying she's mocking, but she's bringing up a really good point that you're right. It's easier to understand the former literature. If we don't move the culture quickly enough to change practice, we won't have enough evidence or experts to support that practice. I agree with you, Rachel. It's an issue.
Yeah. And then the second thing is, in this particular case, one of the main issues, which I think we can learn from, is that what happened in this is the patient had this perceived augmentin allergy, and it wasn't documented. And so they came in, they said, oh, we think you have an augmentin allergy. We're going to stop the augmentin. And then they came in and they said, oh, we think you have this orbital cellulitis. We're going to give you ceftriaxone. And so there was no discussion with the parents or acknowledgement that there was a potential risk of this cross reactivity. And if that had happened, likely they wouldn't have this large verdict. If they had said, there might be this risk, are you okay with this? We think the benefits exceed the risk of this, and documented that in the chart, then I don't think we would have seen this large verdict, because there would have been that acknowledgement documentation, which is just so important in these cases. Yes, sometimes you have to give this, you have to take that risk, and you document it, parents acknowledge it, whatever. Then it wouldn't feel like somebody just dropped the ball and killed this kid, which is ultimately what it felt like to the parents. And that lack of documentation and acknowledgement and charting is kind of, I think, what really led to this terrible outcome and terrible feeling for the parents.
I think you're right. Those are great points.
Next one. This is from Dr. Eva Briggs, who took after me, oddly enough, because I kind of suggested that patients who go into urgent care centers are generally not super sick, and that there's this self-selective process whereby the patients who have the subarachnoids don't go to their family doctor. They tend to go to the emergency department in terms of selecting. And the same thing would be true for MI patients, who are more classic than subtle. And she said, not so fast here. In the last 2 shifts, she has seen appendicitis, an inferior MI, a small bowel obstruction, and diverticulitis with abscess for an urgent care center. Now, what kind of urgent care center is this? I tell you. But in any case, she wants, yes, she works in a rural, low-income area. So, Eva, we give up. You win. It's not all the same in the urgent care center. Some of them are sicker than not.
I agree with Eva. I mean, I tell you what, and if you don't have a good primary care base in your community, patients oftentimes don't understand the difference between an urgent care center, a freestanding emergency department, and an emergency department in a hospital. It's got a red sign. It says urgent. It says emergent. I can go there. And I am also frequently amazed at what gets transferred in from an urgent care center. It is scary. You're right. I think you do select out a lot of those patients, but they're also at great risk for not being discovered on the front end, so they can be horrendous.
Yeah, I totally agree. I have friends that work in urgent cares, and one of the things I learned is that they have incentives to not transfer. They kind of get penalized for how many advanced tests they're ordering, how many labs, how much imaging, and how many patients they're referring on to the ED. So their incentive is to do less tests, less referrals. And so they're really trying to minimize all of that. You have chest pain, but I just sent somebody ED with this. I'm going to try not to send you. You hit your head and you're 70, but you look pretty good. I'm going to try not to send you. And I think that's really dangerous because of, what we're seeing here. Really sick patients do show up there and they don't have all the tests. probably we should be referring a fairly high percentage, but those urgent cares are really trying to minimize that. So I also agree with this comment.
All right. Who's next here? Oh, Kevin. No. Rachel,
It's
I think
me.
you're next.
All right. We had a comment from PA Nick Feeson, who wrote into Greg and Rick and said a bunch of nice things, apparently.
She's struggling through this one.
To Greg and Rick. This is old, apparently. But also said that sometimes we're demeaning to APPs and wanted to have an APP on the show at some point. So it sounds like Rick would like to take him up on that suggestion in the future.
Sounds like a great suggestion.
It is. I think it is a great suggestion. And I have been accused in the past of having a somewhat leaning, not supportive of PAs and MPs, and which is, in my view, totally untrue. We started this course called this course called Emergency Medicine Boot Camp. 22,000 PAs and MPs and primary care doctors have taken that course. The whole purpose of the course is to make PAs and MPs as good as they can be within 3.5 days. And I think emergency departments would be honestly foolish to have all of the physicians, all the clinicians be board certified emergency physicians. I think there's a place for integrating PAs and MPs into practice. And I maybe should be more careful maybe in how I choose my wording, but fundamentally, I'm with you. And it's kind of like, so it hurts me a little bit when I get perceived to be
Don't feel hurt.
anti.
I think we all agree physician-led team-based care is the way to go, but we have to have responsible skill set substitution for physician level care. And if we really wrap our minds around that, everyone has a critical role to play. And yeah, I will speak to that. For well over a decade and a half, you've been extremely supportive of advanced practice providers, Rick.
Thank you, Kevin.
You're welcome.
What do you have to say, Rachel?
I'm all for it. Let's bring one on and chat.
Do you have PAs in the emergency department, MPs at
No.
where you work?
Not in Arizona. They staff our observation unit, but that's it.
Okay. And one more. Last one.
Do you want me to go to the next one? Well, so this was a thank you to you and to Greg about AMAs. Someone was so thankful about what they learned from you too, about how to appropriately document. And I think that makes a lot of sense. Spend the time, especially in high-risk cases. Somebody wants to leave, we have to be careful how we approach those people. And frequently it's been, fine, you don't want my plan? Then make sure you go ahead and leave now. And I'm offended. And we need to document appropriately, get a signature when we can, but what is more important is to document in the record the informed refusal. And as hard as it is, if they don't want plan A, come up with a plan B. Give them something that helps them along their way to get better, even if it's not exactly what you had planned for them. But it sounds like you did a great job educating and sharing your perspectives with this person, and they were very thankful.
Can I read this one line?
Yeah.
I just found out I was actually left out of a complex case that the hospital and ED staff are currently involved in. Neither myself nor my group, I don't know what that is, nor any other physician were brought into the case. You saved me 5 years of stress, all because you taught me how to document this stuff correctly.
Yeah.
And with that,
congratulations, Rick, and thanks, Greg.
Yeah, thank you, Gregory. So that's catching up on the emails. Listen, we like to get them. Please feel free to send them. You don't have to say nice things. I mean, you can complain about my attitude or whatever you want. But now it's time for part 2 of the show. One of my friends, Mike Ritter, basically has a lot of familiarity with what happens when you get involved in a lawsuit, and the judgment is for much more than your insurance. And because of his expertise in that area and an attorney friend of his that also does that kind of work, Mike Ritter and Mike Bedard are going to be talking to us about strategies to limit your risk of having to pay an what is it called? An over
limits judgment or excess
over limits judgment. Yeah. And I think that we're going to run with that now. Any thoughts before we leave our part one here, guys? Okay, then let's have Mike and Mike take up this really interesting topic. And I'll talk to you guys next month.
All right.
Perfect.
Thanks, Rachel.
Thanks, Kevin.
Well, hello and welcome, Rick Bukata. Time for the April issue of Risk Management Monthly. We have a very special issue this month. With us, as usual, is Rachel Lindor and Kevin Klauer, but we have two guests. Mike Ritter is a friend of mine from out here in Southern California. I've been known him for at least 25 years. Mike is with Providence Mission Hospital in Orange County, where I think, is this the only job you've ever had, Mike? You've been there forever.
I've been there forever, yes.
That's basically your whole career. And Mike's gotten interested in risk management from a couple perspectives, and he is periodically sending me cases that we ought to take a look at, articles that are interesting and provocative, and I appreciate that. We have, Mike, would you introduce our guest today?
Sure. So Mike Bedard is a attorney that's a managing partner of one of the preeminent law firms that specializes in bad faith. And that is the legal area when things go haywire with insurance companies.
Basically, when they're not going to cover you for what you'd hope they'd cover you for.
That's correct. Whether it's a work comp claim or an auto accident or a medical malpractice case gone haywire.
Well, I guess the cases we're going to cover today are where you are being sued for over limits. And not only are you sued for over limits, the jury has basically said you owe over limits. So this is a case where we have some techniques that you're going to tell us about to help mitigate the risks in these situations.
And I have to, can I jump in? I have to say that I was reading through some of the notes on this, and this is an area that we've touched on before in these podcasts. And as I was reading through the notes, I realized that when we were talking about this, we probably got in over our heads. And so I'm excited that we have somebody with some actual expertise to kind of give us the real deal here. So I'm excited just to kind of sit back and listen and get that.
So I'll go ahead and get started. So in 2019, the aggregate data from AON and ASHRM, which is the American Society for Healthcare Risk Managers, put out that there were 106 cases in the United States that exceeded $10 million in terms of the jury verdict amounts. 6 of those cases exceeded $20 million. And they kind of broke down. A third were bad baby cases, a third were failed to diagnose, and then the other third were kind of a mix of medication errors, falls, surgical complications, et cetera. And there's been 2 big cases just this year, one in Idaho for over $10 million. And then in February of 23, there was a case for $47 million in Las Vegas against a hospital over an ER case that ultimately was reduced down to $12 million when they put the caps into play, but still way beyond what the insurance coverage was. So let's start off with the hypothetical case where things go haywire. And the exact details of the case don't matter as much as the consequences of what happens after the trial, which we'll talk about. So the case is an 18-year-old who comes to an ER because of a fever and is worked up, and the physician consults with a hospitalist who says the patient doesn't need to be admitted, go ahead and discharge them. And of course, the patient comes back 12 hours later with meningococcal meningitis and ultimately loses a few fingers and toes and also has a seizure disorder and a brain injury. So litigation has started, and there's 4 people named in the litigation. There's the emergency physician, the hospitalist, the ER group, and the hospital. The experts that look at the case on the defense side say that the care was reasonable and that the labs were okay and that the standard of care was met with regard to taking care of the patient for both the hospitalist expert, and the emergency physician expert. The plaintiff's experts, of course, are very critical of the care and specifically point out that the patient was tachycardic with a heart rate of 120 when they were discharged and probably should not have been discharged from the hospital. The life care plan that was put together by the plaintiff's law firm, and this is the people that say, what is it going to cost to take care of this person for the rest of their life, medical and lost wages, et cetera. Said the patient would have a life expectancy to age 55 and need $18 million. The defense life care plan came back. The patient would live to be 45 and only needs 5.5 million to remedy that. The insurance coverage. So the physician has $1 million policy. The ER group has $1 million policy. The hospitalist has a $2 million policy. And the hospital early on settles for $2 million or some issues that they had. So they jumped ship quickly and settled out. The plaintiff's attorney sends out settlement demands to everybody that's remaining in the case, the ER group, the ER doc, and the hospitalist, asking for their policy limits. These are kind of standard demands that are put out by plaintiff's attorneys. And Mike can talk about this later on about the reason that this is done, partly because they can get more money and pick up expert costs, et cetera, in California. The defense attorney for the hospitalist and the defense attorney for the emergency doc do not recommend settling and say that this is sort of a standard tactic that plaintiffs' attorneys use to try and pressure physicians to settle cases and that the case is defensible and should go to trial. 2 weeks before trial, plaintiff's attorney sends another letter to both the attorneys and says that this case could exceed policy limits and he won't hesitate going after personal assets of the physician and the physician group and the hospitalist if there's a jury verdict that exceeds that amount. And he's done some mock jury trials with mock jurors, and they came back with what seems to be a plaintiff verdict when he presented the information. So the case actually goes to trial, and the jury comes back with a defense verdict for the hospitalist. And they say that they arrived at that conclusion because the hospitalist never actually saw the patient, that he just talked to him on the phone. And of course, during his deposition testimony, he said, oh, they never told me they were that sick, you know, kind of the usual things that happen when people get squeezed on a case. The jury also finds a jury verdict for $18 million against the ER doctor and the emergency physician group. The hospital's already settled out, so that $2 million will be taken off that $18 million jury verdict. And when you take that off, plus the $2 million at the ER group and ER doc, at least $14 million is uncovered at this point. So what happens next when this happens? 3 days later, after this jury verdict, all the partners in the emergency group get a notice of intent that they're going to be sued and brought into this. And there's some post-trial motions in front of the judge. And one of the things and reasons that the judge leaves all the ER doctors in is it turns out that it's a Democratic group. And when they all signed their hospital contract, they signed it in their personal capacity rather than putting Inc. at the end because they were all S corporations. And since they signed in their personal capacity, their corporate veil could be pierced. It would not protect them and not protect their personal assets. So the physician group reaches out to a bankruptcy attorney and also an appellate attorney. The bankruptcy attorney asks the following questions, which will send shivers up your spine. The first is, with your corporations, do you have really good corporate compliance? Do you do annual filings with the state of California? Do you have corporate minutes? Do you have corporate proceedings? And do you have financial corporate compliance? And most doctors that have corporations do it for the tax benefits, but may not get bogged down in the weeds of actually doing that. Then the bankruptcy attorney asks, each of your doctors have 401k retirement plans. Who maintains the actuarial aspect of the 401ks to make sure that the physician assistants that you hire, which are employees, have what's called pension parity, meaning that companies in the old days could pay the executives a ton of money and give them huge pension benefits, and then the employees would get less. But there's now a concept of pension parity. They also ask if the 5,500 federal tax forms are filed every year on each of the individual pensions as well as the group pension plan, and then ask, are your PAs highly compensated employees or not, which is clearly defined in the Federal Register as, at this time, was $120,000. So if you have part-time PAs, they're non-highly compensated employees, and the proportion of pension to them is actually higher than somebody that's highly compensated. And so you don't have pension parity. Why does the bankruptcy attorney ask this? Because the plaintiff's attorney that's after everybody is going to try and go after those pension plans to get the money. And the bankruptcy attorney says that if that happens, that the 401ks will not have ERISA protections. That's the federal law that protects pensions from being taken in lawsuits and provides all sorts of pension security. And when that happens and that money's taken out, those plans will be disallowed. You'll have to go back and refile your taxes every year that you use that as a deduction, because that's no longer deductible because it wasn't a legitimate plan. And all the money that was earned on that plan will have to be paid as capital gains, just as if it was ordinary income invested in the stock market. So you lose all the money, and then you still got a bunch of taxes, penalties, fees, and fines that have to be paid as well. Then after this catastrophic news, the group reaches out to a appellate attorney and says, well, we'll just appeal this. Well, in California, to do an appeal, you have to post a bond 1.5 times the amount of the jury verdict that's at play. So in this particular case, we're talking about $14 million roughly, which would require a $21 million bond. And you can't just go get a $21 million bond without putting up collateral. So the appellate attorney says, well, you can put up all your pension plans in your homes, and then if we're successful on the appeal, that'll be great. But if you lose, those assets will be executed on, and you will just lose them immediately. So the other piece of it is that during the appeals process, there's a 10% per year interest that's charged on that amount of money of the jury verdict. And if the case is upheld by the appellate court, then not only do you have to pay the 14 million or roughly that, but you got to pay 10% on that per annum. So, a couple of years of that could push you up to another, add another $2.5 to $3 million to the case of what has to be paid out. So each person is basically facing personal financial ruin. So after your heart rate drops below 100 beats per minute 2 days later, you kind of say, what in the heck are we going to do? And what can be done to sort of prevent this sort of thing from happening in the first place? And that's where an attorney like Mike Bedard comes in, who can help deal with this. Hopefully you can retain him before these cases go bad, but there's a lot of things that can be done to prevent this from ever happening in the first place. So with that, I'll let Mike sort of talk about the area of law that he specializes in, and then we'll ask him some specific questions.
Good. Thank you very much, Dr. Ritter. And I'm pleased that this is being recorded, because everything I say here, I'm saying knowing that it's being recorded, which should tell you that I have a high degree of confidence in anything that I'm saying. And I would say for anybody who, in a short session like this, when it's the first time they've heard some of these ideas, they might want to come back to the recording to listen to it again. So first of all, starting with the general, you referred to me being an insurance bad faith lawyer, and I think it's important we understand what that means. Bad faith, and this is under California law, and California law was at the forefront of all of this. It was the first State of the Union going back to late 1950s, where this whole idea of this new tort remedy having to do with insurance basically grew out of the common law of the courts here in California, and has since been adopted by almost all jurisdictions in the country. So everything I'm saying here today clearly is based upon California law, but depending on what jurisdiction you're in, there may be subtle minor variations, but by and large, it's the same everywhere now. And the idea is this: the relationship between an insurance company and its insured is a special relationship because unlike any other product in the marketplace, when you buy insurance, in this case, professional liability insurance to protect you from claims brought by patients that you serve, that you bought that insurance not with any profit motive in mind, but rather just for peace of mind and protection. And that unlike any other product in the marketplace where you pay money for the product, in exchange, you get some immediate utility. If you buy a gallon of milk, you pay money for it, you bring it home, you drink it. If you buy an automobile, you pay for it, you take it out, you drive it. Everything you can think of has some immediate utility. Insurance is the only product in the marketplace where you pay for it in hopes you never need it and never you need to use it. So what are you buying? You're buying a notion, an idea of protection for the eventuality that you may be sued one day. And humans being humans, they make errors, and you are buying a product which recognizes that professionals make errors too, and that if that were to occur, that you're protected. So that's the general notion. And the courts came to find that because of that, you need to have special rules that apply. Special obligations are owing by insurance companies to their insureds that are not owed by any other person or entity in the marketplace by virtue of this special relationship. And those obligations are called implied obligations under the law, such that the word bad faith is really a misnomer. It's really, the name of the tort itself is breach of the implied covenant of good faith and fair dealing. So it's a mouthful, but here's how I like to explain it. When you get your insurance contract, there are words written there in your insurance contract. All of those words that are written are expressed covenants. Those are expressed promises and obligations of the parties. And so another way of calling that the breach of the expressed obligations is just the traditional idea of breach of contract. We all know what that is. Breach of contract can occur not only of a professional liability policy such as this, but any contract you enter into, landlord, tenant, purchase and sale of real estate, whatever the case may be, you can breach a contract. But the remedies for the breach are different when you're dealing with an insurance company, and only with an insurance company are these special obligations recognized due to that special relationship. When you buy your liability insurance policy, the relationship between you as medical doctors and your medical malpractice carrier is really not unlike the same relationship you have with your automobile liability insurance on your car, or your homeowner's policy, which insures you for injuries you may cause for lack of due care to visitors to your property or for your personal conduct. All of them are insuring you against your negligence, your unintentional misconduct for lack of ordinary care, or in the case of professional medical insurance, for giving care that falls below the standard of care negligently. In all of those policies, there are two separate obligations that are expressed in writing in the contract. One is the duty to defend in the event of litigation, and the other is the duty to indemnify. The defense obligation is if you get sued, you tender it to your insurance company. Your insurance company and these medical malpractice insurance companies have panels of lawyers who do nothing but defend medical malpractice claims. And that's the defense obligation under the policy. And ordinarily, with medical malpractice policies, that obligation is over and above your policy limit for indemnity, meaning that if you have a liability limit of, say, for example, $1 million on your policy, that defense obligation to pay the lawyers, et cetera, is payable by the carrier on top of the protection of $1 million. The $1 million limit, policy limit, whether it's $1 million, $5 million, $10 million, whatever you've purchased and paid for, that is the amount of money that the carrier needs to pay to indemnify you for any eventual judgment that you suffered. But that's the cap of their liability. So now the question in the case that you're talking about actually is remarkably similar to other case I've had, where the problem is this: it's not the breach of the defense obligation, which is an expressed obligation. The indemnity obligation never arises until there's a judgment. But in between those two obligations, which are expressed in the contract, there's an implied obligation, the duty to settle the case. And this is the core of the fact situation you gave, Dr. Ritter, and that is that during the course of the litigation, the plaintiff lawyer made what you called a demand to settle, a policy limits demand, which you were told was that it was something common technique of plaintiffs. Well, it is true that a policy limit demand is commonly made, but the reason it's made is not only to trigger the penalties for failure to accept interest, etc., but the law in California, going back to the very beginning of the tort of bad faith, arises out of this very notion, and that is, if a plaintiff, through their lawyer, offers to settle a case for within the available policy limits. I'm going to go slow here because this is the core of the whole problem. If a plaintiff lawyer offers to settle a case for within the policy limits at a time when liability is reasonably clear and the damages are likely to exceed the policy limits, the carrier must settle the case to protect the insured, or it fails to settle at its own peril. What does that mean? It means that if an insurance company receives this offer to settle, it must do so if liability is reasonably clear and the damages are likely to exceed. Now then, one of the big problems, and what arises in medical malpractice cases particularly, is that unlike an auto liability policy, for example, in an auto liability policy, if an offer comes in to the insurance company does not need to have the consent of the insured to settle the case. But in medical malpractice policies, statutorily, there is a requirement that because settling a case for a doctor may cause regulatory implications against the license, et cetera, that the carrier must obtain the consent of the doctor to settle the case. And this is where this is so dangerous for medical doctors, because here's the tension. On one hand, in all the cases I've ever seen, I've never yet seen a doctor that has said, you know what, it's absolutely clear, I messed up, I committed negligence, I'm wrong on this case. The defense sets in, you want to believe that you didn't do anything wrong, and so then that translates into not giving consent. What everybody needs to understand is that when you fail to give consent, either because the defense lawyer tells you, hey, I can defend this case, I can win this case, or the carrier says, this is a good defense, you shouldn't have to settle this case. If you either yourself believe that you don't want to give consent because you think you did nothing wrong and you're afraid of the implications in terms of your license, or because the carrier, because in a case I had, a similar case, the carrier created a document where they had the doctor sign saying, I refuse consent. The doctor had no idea the legal effect of that refusal of consent was, because here's what the effect is. If you refuse consent, you've now shielded your carrier from any excess liability if the case goes to trial and you have an excess verdict, because the carrier's defense will be, I could not settle the case because I didn't have the contractually required consent of the doctor to do so. It's up to the doctor to make that decision. And now the doctor is fully liable for everything above the policy limit. Now, in that case, even faced with the doctor having signed off saying, I refuse consent, we were able to overcome that because the trier of fact found that it was not knowing consent. It was not truly explained. And in fact, it was the product of misrepresentation and bad faith conduct in asking for it in the first place. And so what happens is in that setting is that the moment that offer to settle comes in from the plaintiff, the relationship now changes. What do I mean by that? There's now an inherent conflict of interest between the insurance company and its insured. And that conflict of interest, the law in California requires that the insured be notified of that in writing and told that they have a right to seek independent counsel of their own choosing at their own expense. But they have to know, because a well-informed medical doctor faced with that would go to a lawyer who would explain, hey, you need to understand that if you don't give consent and you don't arm the carrier with that consent, they have no obligation now for any excess verdict. So that's a very dangerous moment in any litigation. So I guess the one thing I would say there is, in the event you're ever sued for malpractice, from the very beginning, you should notify the lawyer and the carrier that if there is an offer to settle for within the policy limit, that you immediately be notified of that in writing. You want to protect yourself. So I'm going to pause there and see if you have a follow-up question, Dr. Ritter.
Yeah, can you just talk about the conflict of interest that the defense attorney has between the physician client and the insurance company?
Yes, there is an inherent conflict of interest anytime that a lawyer, in no other setting can a lawyer represent conflicting interests at the same time. However, the case law allows what's called a tripartite relationship in this setting, and only in this setting, where a lawyer representing the insured, paid by the carrier, owes dual fiduciary duties simultaneously, which doesn't exist anywhere else in the law. For example, a lawyer can't come in and represent a buyer and a seller in a transaction because you can't fulfill your fiduciary obligations. However, this fiction that the case law has allowed says, well, the primary fiduciary obligation is to the insured. So even though the insurance company is paying for the lawyer, that lawyer's primary fiduciary obligation is to you, the insured, but it has a secondary obligation not to do any harm to the interests of the carrier. But that is allowed, and that's the very nature of every defense lawyer's obligation in every case where they're being paid by an insurance company. Where it becomes a problem is in the setting of what I just said. When you have an offer to settle for within the policy, now the relationship has changed. And there, the case law says the insured has a right to know that there's a conflict and seek independent lawyer. So now they have someone who's protecting their interests and guiding the decisions regarding consent and acceptance, et cetera. And then if you give your consent, then if you've given your consent and now there's an excess verdict, now you have protection because the law says that the carrier is then on the hook for the entire judgment, irrespective of the policy limit.
So just to make this clear, so what you're saying is that if the doctor consents to settle and the decision is made that the insurance company wants to go to trial, if there's an excess verdict, the physician doesn't have any personal liability.
That's correct. Well, let me clarify that just a bit. Is that the obligation now that the carrier had, they are now on the hook for it. But in the short run, the moment that judgment is entered, as between the plaintiff and the defendant, the plaintiff now has rights directly against the insured doctor over and above the limits. The way that then the doctor can protect himself at that juncture is if the plaintiff is willing to take an assignment of rights now from the insured doctors to go directly against the insurance company. But then in your setting, the same way is the plaintiff is not going to give up collecting the other assets. But now if they lose assets as a result of that execution, then those damages can be recovered by the doctor against their insurance company, which is precisely what happened in that case that we did that was similar.
And how do you properly make these requests with your defense attorney? So you've got this case, it's coming up on trial, and of course there's always potential exposure, and some cases have, it's obvious that the amount of insurance will cover it, but there's other ones where it may not.
Well, one of the big problems we've experienced is that you have doctors, for example, a classic example, I had another case involving an OBGYN, 35-year practice, never had one claim in 35 years, and then had $1 million coverage. A $1 million policy for an OBGYN for at risk for bad baby cases is terrible. That's so risky to be out there practicing with that level of coverage with that enormous risk. But that was the case, and it's the case many times. And so the thing is, they were talked into defending the case, saying we could defend it. You have a good defense, but they never explained that without consent that you're on the hook, and it ended up a $72 million verdict had a present value of $13 million, and it destroyed a practice. So it's so important from the beginning to make sure that you've positioned yourself with your carrier to know that they have your consent to settle. Otherwise, it's the risk is with you, not with the carrier.
Hey, Mike and Mike, I've got a quick comment, and I'd love to hear your perspectives. Would that be okay?
Yes.
If we go one level higher on this, and you focus in great detail on the policy itself, and how a consent to settle clause will work. But I think our listeners really need to focus on what their declaration page says, and if they even have a consent to settle clause in their policy. Most of them will have it, but many of them may not. In particular, if you're insured or your group has an alternate form of risk management finance, they are doing risk retention group, they're self-insured, they have a captive, you may not have this protection. And you eloquently stated that this doesn't always work to your benefit even when you have it, because it's also referred to as a hammer clause, to hammer that individual into settling when you don't feel like you should, because you should defend your reputation. So this is a double-edged sword, but I'd love to hear your thoughts about people protecting themselves, understanding what policy they really have, and if they truly have a consent to settle clause, because it's not necessarily a given that it's always there.
Well, I'll address that. Happy to. And again, I'm speaking, unfortunately, only from the perspective of California, and there may be different statutory requirements elsewhere, so I can't comment on that. But in California, by statute, in any medical malpractice coverage, there has to be a consent clause. It's statutorily mandated to be in every policy. So there definitely is that requirement. Now, if you have some other form, captive or things of that nature, I can't comment on that because I've never been around a captive policy for medical malpractice to see whether or not that statutory obligation also exists there. But you are correct. You need to look at your policy with that in mind from the very beginning, because it's an extra it's an extra obligation or a hoop that the doctor has to satisfy to make sure that that consent is in place for the carrier. Otherwise, they're going to have this defense that they're not liable for anything over the policy limits because they didn't have consent to settle. There was a second part to your question. Now I just brain faded on that. You said something else. I'm trying to think. I wanted to answer it too. I apologize.
Well, I think we started with whether there is a clause at all in the policy, because it can be used as a hammer, as you've stated.
Oh, the hammer clause. That's what I wanted. There is in all of these policies as well in California that I've seen with doctors, there is what you would characterize as a hammer clause. And what that is that it's the circumstances where the doctor doesn't want to settle, but the carrier thinks they do want to settle. In other words, they think the liability is so clear that they don't want to spend the money defending the case, knowing that eventually they're going to have to pay the policy limit anyway. And their provisions I've seen, they have like an internal arbitration system set in where they refer it to a panel, and then the panel makes the decision. So they do have those hammer clauses. But again, that's the reverse problem.
Right.
It is a very dangerous thing for a doctor to, in a serious injury case, to refuse to give consent. And I know that psychologically and perhaps even legitimately in terms of if there's licensing implications because of prior problems or whatever, again, like anything else in life, there's a cost-benefit analysis that has to go on. But that's a very dangerous proposition.
Right. And that's why it's a double-edged sword here. And people have to realize how it may be used to their benefit, how it may be used to their detriment. And great conversation.
And I think just jumping in on this as well, I think Greg Henry so eloquently pointed out the purpose of insurance is to protect your assets. It's not to protect your reputation. And if you're facing personal financial ruin in a case, things can go south really bad. We in our partnership actually changed the partnership so that with the supermajority vote, we can override somebody's decision not to settle a case. And that would prevent somebody from making a bad decision. The problem is the person being sued is probably the worst person to make the decision about whether to settle or not. There's tremendous emotional pressure and sort of a loss of self-worth when you say, I'm just going to settle this case and give up, because everybody wants to fight it all the way to the United States Supreme Court, but it doesn't quite work like that.
So, Dr. Ritter, when you were talking, you kind of talked about a bunch of loopholes that I think people are not aware of how people might get to your personal assets. And I think the point I was making before we started is when we've talked about this in the past, I think we've kind of oversimplified, so people can't get to your assets. You can, put them in an LLC, period. So obviously we've oversimplified that. How do you advise people, who might be listening, how they should protect themselves better? What steps should they take? Do they just need to kind of hire a lawyer when they're, setting up their assets and setting up their businesses? What's your advice that you've had now that you've had this experience for people that are listening, that are thinking, oh my gosh, that could be me?
So our group has a business attorney that does all of our corporate compliance for both the group and the individuals. And that includes annual minutes, our meeting, filings with the state, all the regulatory stuff. It's $600 a year per person. It is money well spent. Doctors are inherently cheap and don't want to spend money on things like that, but those types of corporate compliance things are important. The second piece of it is the appreciating how dangerous your pension plans are. We really get a sense that pensions are just off limits for everybody, but that's not always the case if you don't have proper compliance with it. And other thing, I have a good friend that's a bankruptcy attorney, and I was just talking about this last week as preparing for this show. And he said the other area where people get in trouble with pensions is they overfund them, because no one really kind of monitors how much money you put in, and you do your tax form and say, I put my, $25,000 in for the year, but they're really putting in $100,000. And if you overfund it, then that can also be disallowed. And then all that money is just easy pickings for the plaintiff's attorney.
So for people that might have made these mistakes already, can you just go hire a corporate attorney and have them look through everything? Like, where do you start? Because people are probably in a pickle already that you might have scared to death now.
Yeah, and I'd be happy to give the name of the guy that we use. We did an extensive amount of research, but we've got a corporate attorney. That's all he does is set up corporations and do corporate compliance. He'll clean up your act and get everything in order for you. And then we also use a pension actuarial company that looks at all of the pensions for everybody and looks at the employees' pensions and just make sure that there's pension parity. And we were really on the straight and narrow with that anyways, but now it's all documented and it's really makes it bulletproof where it's just no one can get to it.
You've gotten religion in terms of protecting yourselves, and everybody else who's listening is saying, oh God, oh God, oh God, because we don't have any of this stuff, or the T's aren't crossed, or the I's aren't dotted, or you didn't submit your annual minutes, or this, that, or the other thing, and you just know you have a corporation, but you don't act like a corporation. Like you don't sign your name with ink after it. And I've seen people get into trouble for doing that.
Yeah,
That
just
makes
not even
sense,
having
Rick.
the commingling of funds is another concept that comes up where you don't, you get a corporate check and then you deposit in your personal account. You'd have a business checking account and then you write yourself a check out of that to your personal account. There's all sorts of things. And the corporate compliance attorney's got a whole checklist of here's the top 20 things doctors do wrong with, managing their corporation. And it's all really simple things, but nobody's ever taught us that.
The other thing, when you're buying your insurance, you need to, if you're going through a broker or however you're acquiring it, you need to pay attention to your policy limits and get pricing at different layers of coverage, and also price umbrella or excess coverage. Go to the marketplace and make sure that you're exploring keeping your limits higher than you might have them now, because there is definitely verdict inflation going on for sure. There's been a lot of increase in the results, jury verdicts over the course of the last couple of years.
Mike, the challenge for us is that oftentimes in emergency medicine, almost exclusively actually, we are given professional liability coverage as a benefit. So we're not procuring our own coverage. But we really need to focus on when you're in that courting phase, let me see a declarations page. Let me see what you have. Let me see your limits. Let me see if there's a consent to settlement clause. You need to know what you're getting. It's not always an apples to apples comparison. And so I think you really need to know. I tell you, I share a slightly different perspective than I think you do regarding increasing your limits. My personal experience, and I won't go into the details, but having excess layers in place and then removing them actually reduced severity of claims, reduced number of claims. You can make a target out of yourself. And I think every group has to really decide which is best for you. And that's a tough decision. And just going back to, I got a second, just going back to Rachel really quick, I think Dr. Ritter has really outlined a great way to protect your assets from a corporate standpoint. But I tell you what, your personal assets, you want to make them difficult to discover. You want to make them difficult to access. But there's nothing that completely insulates a debtor from coming for those assets if you need to. I haven't found the perfect thing yet. The closest thing that a lot of people are uncomfortable with is putting those assets in a spouse's name. And that sometimes helps you more than anything else, but sometimes that invokes a little bit of discomfort for some people. That's a real challenging discussion. If you want to take a look at something, I don't remember the details, several years ago, I did a point-counterpoint with two individuals in ASEP Now about whether you protect your assets or you don't. What should you do to protect yourself from professional liability and avoid bankruptcy? And that's available online. Just look it up. ASEP Now, professional liability, protect your assets.
The one thing, there is that common perception that you make a target out of yourself, but at least in California, until there's litigation, they wouldn't know your limits before they sued you in the first instance, unless you're in a jurisdiction where you're required to disclose your limits prior. For example, lawyers have an obligation to say, I do carry malpractice insurance. You're not required to say how much it is. The only time they would find out what your limits are is after you've already been sued. But again, you may be in a jurisdiction where there's a different rule. So
Kevin,
Yeah, there are some different rules. And also my perspective has been too, the first question in discovery is give us all available policies and give us your limits.
yeah.
And I would tell you, demands have been adjusted accordingly.
Oh, of course, no question, because the offer to settle is always going to match the policy limit. But the point is that the protection level is greater too. In other words, it's an inverse correlation. Your risk of demanding that they settle and to give your consent, for example, it's a much different inquiry if you have 10 million in coverage versus $1 million in coverage. Because there's a lot of cases that are going to fall within that limit where you wouldn't have to give consent if you think it's really a defensible case. But when you're an OBGYN and you're getting claims in and you only have $1 million in coverage on a bad baby case,
Yeah.
you'd be crazy not to give consent.
I agree.
Yeah.
Hey, Mike, do the attorneys ever get sued when these cases go south? Like the defense
In other
attorneys?
words, if your
Like
question
legal
is,
malpractice?
do they ever? The answer is yes. I don't like to sue the lawyers that are defending the people unless they just blatantly did something wrong, like not giving proper notice of this conflict or whatever. But the point is this: the best thing that could happen to the insurance company in a bad faith case is for you to also sue the lawyer, to blame the lawyer, because that's what they want to do in the first instance. The only reason we did this is because this defense lawyer, who owes his primary fiduciary obligations to the insured, not to me, or not to us, the carrier, told us that they could defend the claim. So it's not our fault. We relied on the advice of this lawyer. And if you sue that lawyer, you're really buttressing their argument. And there's a lot of remedies that are available against the insurance company who's really driving the boat that you don't have against the lawyer. So strategically, it's normally not a good idea.
And then, Mike, do you consult with people before trial? So can they reach out to you, in other words, and say, what do I do to help protect myself?
A big part of my daily life is providing advice that ends up being my pro bono work, because I'm doing that all the time, giving people advice on what to do. Send a letter, do this, do that. Yeah, happy to do that. Unfortunately, the cases that we really take that have the economic viability for us to be able to get money, the train wreck has already occurred, and as you know, that happens.
Yeah.
And Mike is with Chernoff Bedard at your
Yes.
in Claremont, which is beautiful town here in Southern California. That's where all the Claremont colleges are, and so he's readily available in Southern California. Anything further?
It's a lot of scary stuff, but education is paramount, just like everything. Being well educated about how to manage a complicated airway or how to deal with a complicated case. We assume that our attorneys have all the answers, but it's a complicated answer.
And the only final additional comment is that the reality is, whereas the primary fiduciary obligation of these lawyers that do the work for the carriers is to the insured, face it, their repeat business comes from the carriers. They get over and over and over repeat business from the same carriers. They're not going to be doing things because that are adverse to the carriers' interests, and that's one of the practical problems. But it's not only in medical malpractice; it's in all insurance cases. Automobile liability carriers use the same law firms over and over in given jurisdictions. Homeowners, carriers, the same thing. These are old relationships that exist. And so that's the problem.
Well, knowledge is power. And just like many things in life, including medicine, if you know more, you take power back over the control of your own destiny. So you've got to know your circumstances to be able to protect yourself.
Right.
This is one of those, you don't know what you don't know. And basically you can get in big trouble, especially when it's involving money. And Mike, your restating of Greg Henry's phrase about protecting your assets versus protecting your honor is, if you want to do that, he said go into a sword fight or a duel or challenge somebody. But this is not the arena to do it in. Hey, listen, I thank you all for being here. We learned some scary stuff now. But I think it's actually really, really important stuff, because most of this can be handled in advance by doing some of the things that Mike talked about. When you actually get into trouble, it may be much more difficult to unwind some of this. So, Mike and Mike, thanks so much for being here, and Rachel and Kevin, again, thanks so much, and I hope your mom's doing okay, Kevin. I think we lost Kevin. Okay, thank you all. I very much appreciate it.
All right. Thank you. Have a great day.
Thank you guys for taking the time.
Bye-bye.